Welcome to our live webcast, Updates in ATTR Cardiac and Neurological Amyloidosis, What's New and Exciting for 2022. Thank you for joining us. My name is TJ and I'll be the facilitator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you will see the text chat window. There's a large window which holds all your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they are received and will be addressed at the end of the presentation. We are joined today by our speakers, Frederick L. Ruberg, MD, Omar K. Siddiqui, MD, Michelle Kaku, MD, and K.H. Vincent Lau, MD. Frederick L. Ruberg, MD, is an associate professor of medicine and radiology at Boston University School of Medicine and clinical cardiologist at Boston Medical Center, specializing in cardiac imaging and infiltrative heart disease. He attended the University of Pennsylvania School of Medicine, completed internal medicine training at Brigham and Women's Hospital, cardiovascular disease fellowship at Boston Medical Center, Boston University School of Medicine, and a fellowship in cardiovascular magnetic resonance imaging at Beth Israel Deaconess Medical Center. Dr. Ruberg has an active clinical practice as the senior cardiologist in the BU-BMC Amyloidosis Center. He is Associate Chief of Cardiovascular Medicine for Academic Affairs, Associate Director of the Cardiovascular Medicine Fellowship Program, Director of the Cardiac MRI Program at BMC, as well as the Integrated Pilot Grants Program of the Boston University Clinical and Translational Science Institute. Dr. Omar K. Siddiqui is a non-invasive cardiologist at Boston Medical Center and the Boston University School of Medicine. He is the Program Director of the Cardiovascular Medicine Fellowship at Boston University and an educator at the Boston University School of Medicine. Dr. Siddiqui attends in the Cardiac Amyloidosis Clinic at the Boston University Amyloidosis Center. His research interests include the development and supervision of clinical trials, particularly those testing novel cardiac amyloidosis therapies. Michelle Kaku, MD, is an assistant professor of neurology and neuromuscular specialist at the Boston University School of Medicine. She has special interest in neurologic manifestations of amyloidosis as well as small fiber neuropathy and myasthenia gravis. She has been part of the Amyloidosis Center at BU for the past 6 years and has participated in several amyloidosis clinical trials. She has also served as program director to the neurology residency for the past 4 years. Dr. K.H. Vincent Lau is a neuromuscular amyloidosis specialist at Boston University School of Medicine. He is also the outpatient medical director for the Department of Neurology. He joined the Amyloidosis Center after completing a neurology residency program at Yale New Haven Hospital and neuromuscular fellowship program at Harvard Mass General Brigham. His research in hereditary amyloidosis, specifically on neurofilament light chain as a biomarker for neuropathy, is supported by the Amyloidosis Foundation.
Hello, my name is Rick Ruberg from the Boston University Amyloidosis Center and Boston Medical Center. I'm delighted to be working today with Dr. Omar Siddiqui, and we are here to present to you updates in ATTR cardiac amyloidosis. What's new and exciting for 2022 and beyond? So let's start by making sure we're all on the same page about what is amyloid and what is amyloidosis. So as we all probably know, amyloid is a problem with protein folding. And this cartoon here illustrates how a protein is made. This blobby thing here is called a ribosome, and you can see how this ribosome is taking a strand of mRNA and transcribing it into a protein. Amyloid is a problem with protein folding, and amyloid refers to the protein. Amyloidosis is the disease that results from deposition of this misfolded protein. And I say misfolded because proteins normally fold on their own, and they have a special way in which they fold and then perform their normal functions. But sometimes proteins misfold, and when they do misfold, sometimes they can orient themselves into a particular way and then come together or aggregate into these things called amyloid fibrils, which look like needle-like structures under the microscope. When these misfolded amyloid structures deposit in the organs of the body, they cause those organs to misfunction. There are over 35 different proteins in the body that misfold and cause amyloid, and they're abbreviated with an A for amyloid, followed by an abbreviation for the protein that misfolds, like ATTR, which is transthyretin. Amyloid diseases are similar to Alzheimer's dementia because in Alzheimer's disease, a protein in the brain misfolds and causes disease, as we believe. But the systemic amyloidoses, the amyloidoses that occur in the body, are different than the protein that causes Alzheimer's disease in the brain. This is a slide from a microscope showing a heart specimen. The red area here is taken up a stain called Congo red, and these are amyloid deposits in the heart muscle, and this is a heart muscle specimen. This is what it looks like under electron microscopy, and here you can see those fibrils, those needle-like structures caused by aggregates of amyloid protein. Amyloid protein deposits in between heart cells. This is another different biopsy specimen of the heart showing the pink or purple, heart muscle cells, and the lighter purple material between those heart muscle cells is amyloid. So when amyloid deposits in between these heart muscle cells, it causes the heart to become thicker and it causes the heart to become stiffer. The heart loses its normal elastic properties. These amyloid deposits also can directly injure the heart cells, causing, unfortunately, them to die and therefore not be able to perform their function. We're talking today about TTR, or transthyretin. TTR takes its name from trans, which stands for thyroid hormone. So TTR, this is a picture of TTR in its kind of cartoon form. It binds to thyroid hormone, and transretinol, that's what the trans comes from. Retinol is vitamin A. So TTR is a protein that transports, that's the trans, thyroid hormone and all trans-retinoic acid, or vitamin A. It turns out that TTR is not a very important transporter for thyroid hormone, but it is a very important transport structure for retinol, or vitamin A. And this explains why when you take certain therapies, certain drugs, you need to take additional vitamin A because of the suppression of the TTR protein. TTR is made by the liver, illustrated in this cartoon. Interestingly, the liver is not affected by TTR amyloidosis, but the liver makes TTR, and as I showed you, the ribosome transcribes it into its protein, and it exists as 4 separate parts, subunits. It's also described as a 4-leaf clover sometimes in the way it appears. And as I mentioned, sometimes this protein breaks apart and misfolds. And when it misfolds, it then begins to go through these different intermediate steps and ultimately aggregates as those needle-like structures called amyloid fibrils. In TTR amyloidosis, the principal organs that are affected are the heart, causing something called a restrictive cardiomyopathy, and the nervous system. And that's why today we've broken this presentation up into 2 parts, a part about the heart and a part about the nerves. Why does TTR misfold? Well, in some cases, we understand better than in other cases. Some people have unfortunately inherited variants in the TTR gene, a switch in the structure of the gene that causes this protein to be unstable and misfold. We call this hereditary ATTR, or ATTRV. We say hereditary because the gene is passed on from parent to child in a manner that is called autosomal dominant, which means that 50% of a person's children who has ATTR variant amyloidosis, their children will also have that 50% of the time. Sometimes TTR misfolds in the context of normal gene structure, and we don't really know why that occurs, although there's certainly a lot of good ideas we could talk about in the Q&A. We call that ATTR wild type. Wild type is a genetic term or description for no variants, the type that most people who are walking around carry. We do know that wild type TTR is associated with aging and seems to be associated with being male, but again, we don't completely understand why that's the case. So this slide kind of brings home the basic biology of how a gene functions. And it's important to understand because we have therapies that treat TTR amyloidosis at each level. This is the level we just talked about. The ribosome makes a protein from mRNA. We call this translation. And we have drugs that actually work at the protein level, that stabilize the protein and keep it from misfolding, as you will hear from Dr. Siddiqui, Kaku, and Lau. We have drugs that actually stop the protein from being transcribed or destroy the mRNA transcript, so you can't make TTR anymore or make very little. We call those silencing medications, and they work at this level. And finally, we have medications that even work at the DNA level. New medications that are still experimental and are being tested change the structure of DNA such that the TTR protein isn't even made at all, and there is no or minimal mRNA transcription. Now, this is a still frame image of an echocardiogram of the heart. And what happens with amyloid, as I showed you, when it affects the heart becomes thicker. And here you can see the echocardiogram is playing, which is helpful to illustrate that under normal circumstances, the heart looks like this, and under amyloid, the heart looks like this. And you can still hear, even if you're not a cardiologist, that the heart is really thick compared to this heart here. Each one of these dots is a centimeter. And this is what the amyloid looks like under an echocardiogram and how an echocardiographer might make the diagnosis of amyloidosis. The principal problem amyloidosis causes is called congestive heart failure. Congestive heart failure is not a heart attack. We call that myocardial infarction in medical terminology. A heart attack is typically when the heart becomes injured by interruption to blood flow. It's not cardiac arrest. Cardiac arrest is where the heart stops circulating blood entirely, typically by a heart rhythm problem. No, heart failure is a problem where the heart still beats. It's not a heart attack, but the heart doesn't do its job well. It inadequately circulates blood to the body to meet its requirements, and it doesn't do it at the right pressure. And so that results in the heart being, it can result in the heart basically pressures being higher, which causes symptoms of, as I'll show you, of congestion, so symptoms of shortness of breath or swelling in the legs from the high pressure. Or it causes symptoms of fatigue and weakness because of the low output. So as I mentioned, the signs and symptoms of heart failure are shortness of breath that can occur with exerting oneself or lying flat or at night. It causes swelling of the legs and abdominal bloating or increased weight gain because of fluid collection in the abdomen. It causes low blood pressure because of the reduction in the output of the heart. And as I mentioned, because the circulation is poor, people feel tired and weak and have low energy. Now, these, as you know, are relatively nonspecific symptoms. There's lots of different medical conditions that can cause heart failure. But we as doctors are trained to understand the constellation of symptoms in combination to recognize it as the syndrome of heart failure. I'm now going to speak about the symptomatic treatments for heart failure. And Dr. Siddiqui will be speaking about the specific therapies for amyloidosis. So in cardiac amyloidosis, we treat it differently than we treat other causes of congestive heart failure, say, for example, from a heart attack. There's no guideline-directed medical therapy, as we say, in other forms of heart failure, largely because large studies haven't been done, but also because the things that we use to treat other forms of heart failure don't really work very well in amyloidosis. We focus mostly on controlling the amount of fluid in the body. We call that volume control. And the concept here basically is that if you reduce the amount of fluid in the body, the pressures in the heart are lower and the symptoms of congestion are better. And the mainstay of therapy there involves loop diuretics. These are medicines that are given that work on the kidney and a particular part of the kidney, the loop of Henle. And these medications are listed here. And they tend to be very effective in reducing the volume of someone's blood circulation by making people pee more. Now, the side effect is you can go too far and cause people to become dehydrated, and that can result in kidney dysfunction. So your doctor will follow very closely how your kidneys are performing with these medicines and following your symptoms. We also now, in 2022, very commonly use mineralocorticoid antagonists. This is a class of medications that became very popular because they were found to be very effective in treating other forms of heart failure. This is an example of how other forms of heart failure that are guideline-directed do work in amyloidosis. And the medications that you see here, spironolactone and eplerenone, are the ones that are available and most commonly used. The side effect of mineralocorticoid antagonists are high potassium, and also in some men, they can develop increased tenderness in the nipple area or the breast tissue. We call that gynecomastia, which is not a side effect of eplerenone. And these are side effects that your doctors will monitor for. Now, in symptoms of situations of advanced heart failure, where the blood circulation is really poor, blood pressure is really low, or the symptoms of congestion are really difficult to control, we would consider either heart transplantation or the use of special pumps that we insert in the body called mechanical circulatory support, or VADs, ventricular assist devices, to help support the circulation. We can also treat low blood pressure with medications. Low blood pressure can result from dehydration, as I showed you before, when you take too much fluid out of somebody's circulation, or in the case of ATTR amyloidosis, as you'll hear in detail from our neurology colleagues, from autonomic neuropathy. The nerves are injured by the amyloid deposits, and they don't function very well. And in hereditary amyloidosis in particular, and in that setting, the nerves that control blood pressure can also be injured. So we treat that by either lowering the diuretic dose because we've diuresed someone too much. We can have people drink a little bit more water, or we can give them medications that actually raise blood pressure, and you can see the medications used here to do that. Finding the right balance of blood pressure and fluid volume can sometimes be very challenging, and that's why our neurology colleagues and cardiology colleagues work together to find the best balance for a particular patient. That underscores also why a multidisciplinary approach is so important. ATTR amyloidosis also causes problems with heart rhythm. The most common heart rhythm problem that patients have is atrial fibrillation or atrial flutter. And this is a problem where the upper chambers of the heart no longer beat rhythmically, or they beat in such a way that they increase the risk of forming a blood clot in the upper chambers of the heart. We'll talk about treatment for that in the next slide. Sometimes the heart rhythm can be too slow. We call that bradycardia. Sometimes the heart rate can be really slow and result from heart block, which are conduction problems where the wiring of the heart's damaged. And sometimes the heart rhythm can be too fast. We call that ventricular tachycardia or even ventricular fibrillation. How do we treat this? Well, the signs and symptoms can be palpitations if the heart rate is too fast or irregular. It can result in passing out or dizziness if the blood pressure is too low from a too fast or too slow heart rhythm. Sometimes people just sense their heart rate is not beating regularly, particularly when they're lying down at night or sleeping and they're more attuned to their heart rate. And sometimes in the situation of atrial fibrillation, they can be at risk for stroke or an embolus or blood clot traveling to the rest of the body. Slow heart rates are generally treated by pacemakers. And these are devices illustrated here that are implanted under the skin with special wires that go into the heart. Pacemakers have specific reasons to be placed, and these are well established by heart rhythm experts. And sometimes we place a special kind of pacemaker called a biventricular pacemaker that paces both sides of the heart. On the contrary, on the other hand, fast heart rates such as ventricular tachycardia can be treated by defibrillators. And defibrillators are devices that are placed for primary prevention, meaning to prevent a arrhythmia from happening, or secondary prevention, which is described as preventing another event from happening. Now, defibrillator devices are special devices that are similar to pacemakers and have pacemaking functions but are larger and again are placed under the skin, typically in the shoulder, with special electrodes that go into the heart. And your doctor can review with you the specific reasons for placing a defibrillator or a pacemaker. Now, finally, treatments for arrhythmia have, specifically atrial fibrillation and atrial flutter, are generally formed upon the foundation of anticoagulation. Anticoagulation is thinning of the blood, and as I mentioned, in the situation of atrial fibrillation or flutter, blood clots can form inside the heart. In 2022, we now really reach for these direct oral antagonist medications as opposed to warfarin as first-line therapy. I'd say as recently as 5 to 6 years ago, we were using warfarin or Coumadin as our first-line therapy for anticoagulation, and now we use these newer medications because they have the advantage of not requiring regular monitoring, not having interactions with dietary intake like leafy vegetables, and are simply much easier for patients overall to take. We also may recommend low-dose beta blocker medications in the case of atrial fibrillation, but I capitalize low dose here because higher doses of beta blocker are typically not tolerated very well, and patients feel pretty poorly, tired, have low blood pressure, and cardiac amyloidosis. And we often use medications to control heart rhythm, particularly in situations of atrial fibrillation, which can't be very well rate controlled. And the principal medication we use there is the medication amiodarone. And in some cases, we actually perform catheter ablation procedures to help terminate the atrial dysrhythmia. That often occurs very effectively in the case of atrial fibrillation and less effectively in the atrial flutter, and less effectively in the case of atrial fibrillation. So we would recommend catheter ablation more commonly in atrial flutter rather than atrial fibrillation. But in generally speaking, amiodarone tends to be the first-line therapy for many of our atrial rhythm problems, like particularly atrial fibrillation. And finally, we would recommend a pacemaker under the appropriate circumstances. So I would say in 2022, we've now moved much more towards these new blood thinning medications. And we understand now that really slowing someone's heart rate down is principally helpful in maintaining their symptoms of heart failure control. So now I'd like to turn the presentation over to Dr. Siddiqui, who will speak specifically about treatments for ATTR amyloidosis and focus on the therapies we now have available, the very exciting new therapies for amyloidosis specifically.
Thank you, Dr. Ruberg. This is really an exciting time for us, those of us who take care of patients who have amyloidosis, because there really has been an expansion in our armamentarium of specific targeted therapies for transthyretin amyloidosis. And we're going to focus on the cardiac therapies, on therapies that are used to treat people with heart amyloidosis. I'll touch upon the neurologic therapies as well a little bit, and then Drs. Kaku and Lau will expand on that further in their section of the talk. So as Dr. Ruberg said, the transthyretin molecule is made by the liver, and then it circulates in the body as a tetramer, as a four-leaf clover, which then breaks down and misfolds into these sticky amorphous aggregates that deposit ultimately in various organs, the heart, the nervous system, the soft tissue, in this case of carpal tunnel syndrome, and actually cause disease. So we can intervene at multiple steps along this pathway to prevent the process by which these fibrils deposit in the organs, and I'm going to kind of go through this in more detail. The first step was, back in the 1990s, people were thinking about how to treat this disease, and the idea was that if we were to replace the liver, because we know that transthyretin comes from the liver, if we were to replace the liver, maybe that would silence the whole disease. And that was the thought behind liver transplants, which were really felt to be the original transthyretin silencers preventing production. And so the most famous recipient of this was Governor Casey of Pennsylvania, who underwent a heart and liver transplant for hereditary amyloidosis affecting his heart in 1993. And then you can see that he passed away in 2000, 7 years later. So this was thought to be sort of a game changer. And the first orthotopic liver transplant for hereditary TTR due to the V30M mutation took place in 1990 with good initial outcomes, and the estimated 10-year survival in the earlier studies is about 100%, versus about 56% for people who had V30M amyloidosis but did not undergo transplants. However, the non-V30M, the people who had other mutations did less well, and ultimately what became clear was that patients, despite doing well initially, started developing transthyretin amyloidosis. despite having a transplanted liver, which was sort of intriguing. And it turned out that their existing circulating hereditary amyloid protein was complexing with the wild type transthyretin being produced by their new liver, and it was complexing into this sticky amyloid fibrils in the heart and nervous system. So it was unfortunately not the cure that people thought that it would be. So then there was sort of a gap of many years where we just did not have effective therapies until the advent of TTR gene silencing agents that acted at the level of the mRNA that Dr. Ruberg was talking about. And there are two main kinds of these drugs. One is known as patisiran, which is a short interfering RNA, and the other is known as inotersen, which is an antisense oligonucleotide. And all you need to know about this is that they act at the level of the liver and they disrupt the genetic code, the mRNA that leads to the production of the protein. So they basically degrade the mRNA that would have gone on to form the transthyretin protein. So that's why they're known as gene silencers. They were both tested in randomized clinical trials of patients who had hereditary amyloidosis causing a peripheral neuropathy. So to be clear, these were patients who had neurologic manifestations of hereditary amyloidosis. Some of them also had cardiac manifestations, but these trials were primarily targeting patients with neuropathy. On the basis of these trials, both these drugs were approved in 2018, and this really marked sort of a landmark moment for our field because this was the first time that we had targeted therapies for transthyretin amyloidosis that could silence the gene and prevent production of the protein. Doctors Taku and Lau will talk more about this when they talk about these therapies in the context of peripheral neuropathies. So to talk a little bit more about just the mechanism of how they act, these are injectable drugs. So you either get them via an IV infusion or a subcutaneous injection, and they basically use the cell's own machinery to destroy the mRNA for transthyretin. So then the idea is that if you silence the genetic code that produces transthyretin, no transthyretin protein will be produced, and therefore no amyloid deposits will form. As we talked about, these randomized clinical trials on the basis of which these drugs were approved were basically for people with hereditary TTR polyneuropathy. Some of them did have heart disease. So these drugs are patisiran and inotersen are FDA approved for hereditary ATTR polyneuropathy. And as I will show you later, they're actually being trialed in cardiac amyloidosis as well. Patisiran, so just diving a little bit deeper into this, patisiran is the short interfering RNA drug. It's an intravenous injection, so you'll go to your infusion center and to your doctor and they'll put an IV in and they will give you this intravenous injection every 3 weeks. The Apollo trial was the New England Journal of Medicine trial that I just showed you that proved benefit in a peripheral neuropathy. And currently we're studying this drug in the Apollo B trial for patients with heart involvement with cardiomyopathy. The other drug in the same genre of therapy is vutrisiran. So the other drug in the same genre of therapy is vutrisiran, which is like patisiran, but it's a subcutaneous drug that you get every 3 months. And that was just approved for TTR polyneuropathy and is also being tested for cardiomyopathy. These medications require pretty significant pre-medications to prevent you from having an allergic reaction to them. So your doctors will treat you with steroids, with dexamethasone, with H1 and H2 blockers, antihistamines, with acetaminophen. And as Dr. Ruberg alluded to, because transthyretin is a transport molecule for vitamin A, for retinol, you would also get vitamin A supplementation to make sure that your vitamin A stores are replete in your body. So patisiran and vutrisiran were one type of gene silencers. Another type of gene silencers are inotersen, which was one of the original ones. It's an antisense oligonucleotide, and this is a weekly subcutaneous injection. So you give it, so it's like kind of a shot that you give yourself. It's not through an IV, it's subcutaneous, and it was proven effective in the TTR-RX study. It requires monitoring for platelet levels and kidney function because in the trial, a very small number of people had a decrement in their platelet levels and a worsening of their kidney function. Again, this is not particularly common, but it was something that did happen. It was a side effect. And so inotersen requires regular monitoring of the complete blood count and a metabolic panel to look at kidney function. There is some exciting news in this space because the related agent, eplontersen, is thought to be a safer drug and it's thought to have less side effects. And it's being tested in the CardioTransform study for patients with cardiac amyloidosis. And there was actually recent positive data from the Neurotransform study in patients with neuropathy. And much like patisiran and vutrisiran, this also requires vitamin A supplementation for reasons that we have already stated. And then, taking a step slightly back in the pathway by which TTR is made, and as Dr. Ruberg alluded to, we can now even interfere at the level of the DNA, the actual genetic code. And this is a set of molecular scissors called CRISPR-Cas9, which allows us to actually edit the genome at the level of the DNA, at the level of the genetic code. And so this is very exciting news in 2022. This was a paper that was published in 2021 last year. And these are drugs that can actually permanently silence TTR production. And these are obviously a small trial of 6 patients, but it showed that we could knock down TTR to up to about 87% at 28 days at the highest dose. So this drug is this therapy is being trialed by NTLA, which is the drug company, and there is a phase 1 trial that's ongoing. So that was talking about gene silencing. The idea is to prevent production of the transthyretin protein. Once the transthyretin has already been produced and it's circulating in the body, there are drugs that can act on that tetramer, stabilizing it, preventing it from dissociating, from breaking down and depositing in the heart and the nervous system. And the big drug in that framework or for that purpose is tafamidis. There was the ATTR-ACT trial published in May 2019 in the New England Journal of Medicine in patients with cardiac amyloidosis. So up until now, I've been talking about drugs that have been beneficial for patients with neuropathy, and we're trialing them in people with heart disease. But tafamidis is really the only medicine that has been trialed in a randomized clinical trial for patients with heart disease, with amyloid cardiomyopathy, and it showed that patients who received tafamidis felt better and lived longer. And based on this, tafamidis became the first drug approved by the FDA for treatment of patients with ATTR cardiac amyloidosis, both wild type as well as hereditary forms. There is another drug that is similar to tafamidis called diflunisal. This is a non-steroidal anti-inflammatory in the same class as ibuprofen or naproxen that acts similarly to tafamidis and stabilizes the TTR tetramer, preventing it from breaking down. This was trialed in a randomized trial for patients with familial amyloid polyneuropathy, for those with neuropathy, and showed an improvement, a stabilization of symptoms and some improvement. And it is now we use it off-label. It is not FDA approved for amyloidosis, but we do use it as a TTR stabilizer if patients are unable to get tafamidis. So TTR stabilizers are orally administered small molecules. They bind to the TTR, inhibit misfolding, and they're reversible and short-acting. And there is ease of use for taking a pill rather than having to get an injection or an IV injection or a subcutaneous shot. So these are a little bit easier to take because these are pills. Tafamidis, just to dive more into it a little bit, it's a pill that's taken once daily, and that's the 61 milligram form. The original, and that's known as Vyndamax, it's the brand name. The original formulation, Vyndaqel, was 20 milligrams, and you would have to take 4 tablets of that. Tafamidis is very safe, so it really has not been shown to have many side effects. And as I said, it was proven effective in the ATTR-ACT trial. The survival benefit was seen after 18 months. One thing we tell patients who are on tafamidis is that it stabilizes the transthyretin protein, preventing it from breaking down. And we think that it stabilizes your disease process. Generally, people do not notice a significant improvement in their symptoms, but it may slow the progression of disease. And so it may stabilize where they are in terms of how they feel. And so our idea is to try to give the medicine to stabilize people's disease and to improve their quality of life or to prevent them from getting worse. And like I said previously, tafamidis is the only drug approved by the FDA in the US for ATTR cardiac amyloidosis, and only drug for wild-type ATTR. The other drug that I've alluded to briefly is the oral non-steroidal agent diflunisal, which is used. Actually, this is a drug, and some of you may know this from its use as an arthritis medicine, and it was used in the 60s and 70s as an arthritis medicine. But it was shown subsequently that it also binds to the TTR tetramer, stabilizing it, preventing it from breaking down. It's given at lower doses, 250 milligrams twice a day, than what was approved for its use as a pain medicine. It was proven effective in the TTR in patients with TTR polyneuropathy in the diflunisal randomized trial, but it hasn't been tested in a randomized trial in patients with cardiac amyloidosis. Because it's related to because it is a non-steroidal anti-inflammatory drug related to drugs like ibuprofen, it can cause kidney dysfunction, especially in people who have baseline kidney dysfunction. So we use caution in patients who have existing kidney dysfunction, and we tend to watch people's kidney function more carefully. It can also cause gastric ulcers, and it can cause GI bleeding. This is not very common, but it's something that we do need to watch for. The advantage of diflunisal is that it is inexpensive, and so it is an alternative drug that we use if patients are unable to afford or unable to access tafamidis. And so we also can consider there's a cohort of patients who are carriers of the mutations that put them at risk for TTR cardiac amyloidosis or TTR polyneuropathy, but they do not have evidence of the disease yet. And so sometimes, after discussion with the patient, we may use it in patients who are carriers without signs of disease or who are very early on in their disease in the hopes that it prevents further progression. There is a new drug in this space that is currently in clinical trials that is not commercially available. It was known as AG10 and now has been renamed acoramidis. It binds to a different site on the TTR. This is also a TTR stabilizer, so it's similar to tafamidis and diflunisal. And there's a clinical trial, the attribute trial, that's currently underway. They had a primary pre-specified endpoint, which was the change in the distance that a patient could walk in 6 minutes at 12 months. And that primary endpoint did not show a difference between acoramidis and placebo. Both groups did equally well, but that is not a hard clinical endpoint. So we're waiting for more data from this trial. But that this potentially can be a third TTR stabilizer that we may have access to one day. And so this is just basically a review of the various positions, the various points in the pathway of transthyretin synthesis, where we can act now in 2022 to prevent production and aggregation and misfolding and then deposition of the transthyretin molecule. There's some other drugs that are being developed that are not ready for prime time yet, but the thing about cardiac amyloidosis and amyloidosis in general is that you have this transthyretin molecule produced by the liver, circulating as a tetramer that breaks down into single units that then further dissociate and form these fibrils that deposit in the heart. We can silence the liver, as I showed you. We can silence production of this protein. We can stabilize the transthyretin molecule, but the fibrils that have already deposited in the heart or the nervous system continue to cause problems. And so for a long time, there has been interest in developing antibodies to the TTR, to the transthyretin fibrils in the heart, thereby leaching out the protein that is already deposited in your heart and nervous system, and in the hopes that that will cause reversal of the disease. So these antibodies are in development right now. There are some other drugs. Tolcapone was a drug that had CNS penetration, and that was thought to also degrade fibrils. Doxycycline, EGCG, or green tea extract, taurodeoxycholic acid. There was some kind of modest data about these drugs and their ability to disrupt amyloid fibrils, but it is not very convincing data. And given that we have more promising therapies, these drugs are generally not used in 2022. So this is just a summary of treatment options. The ultimate gene silencer is this CRISPR-Cas9 genome editing. So these are the molecular scissors I was talking about They act at the level of the DNA. It's being made by Intellia pharmaceutical company. The drug is called, or the agent is called NTLA 2001. It's given as an IV infusion. It's currently in phase 1 trials. So it's very early to say what this will look like, but it's very, very promising. And then there's 2 major methods of gene silencing, small interfering RNA. The 2 drugs are patisiran and vutrisiran. Patisiran is given by IV infusion every 3 weeks. Vutrisiran is a little bit more convenient. You can take it every 3 months, and it's a subcutaneous shot. These drugs are FDA approved for hereditary TTR neuropathy, patisiran is, and they're being trialed in other trials now for cardiac amyloidosis. Inotersen is an antisense oligonucleotide given subcutaneous weekly, and its cousin epiontersen can be given every 4 weeks. It's a newer drug. Inotersen is FDA approved for hereditary polyneuropathy, and it's being tested now, or epiontersen is being tested now for cardiac amyloidosis as well. And then the TTR stabilizers that I mentioned, there's 3 of them. Tafamidis is the only FDA-approved drug for ATTR cardiac amyloidosis. Acoramidis is being tested in trials. Diflunisal is a non-steroidal anti-inflammatory that is being used off-label. And then you have the anti-TTR antibodies, which is sort of highly experimental right now, but these are 3 antibodies that are currently being trialed. Some of them are in their planning stages. Some of them, the trials are going on right now. And the big thing, just coming back to tafamidis for one moment, the big problem with tafamidis in the U.S. has been its initial price. So the initial list price was about $225,000 per year, making it the most expensive cardiovascular drug, most expensive oral cardiovascular drug on the market. These drugs are expensive, and that limits the ability of people to access them. But through copay assistance and grants, we have been fortunate that a lot of our patients have been able to afford the drugs without a very high copay. And this is this is done through going through specialty pharmacies as well as various foundation grants. So there's a thought that as more drugs and more treatments are developed for these diseases, that there's going to be competition and there's going to be downward pressure on pricing. So hopefully the price of these drugs will go down. So this concludes the cardiovascular portion of this talk, talking about cardiac amyloidosis and therapies. Again, our thanks to the Amyloidosis Foundation for having us, and thank you all for listening.
Thank you so much for having us here today. So to continue from Dr. Siddiqui and Dr. Ruberg's presentation, we'll be talking about some of the neurologic manifestations that can happen in amyloidosis. So amyloidosis can affect multiple organs due to deposition in these organs, including commonly the heart, as we have heard about, but also in the nerves, in the GI tract, causing various symptoms such as nausea, vomiting, diarrhea, constipation. It can deposit in soft tissue, causing things like carpal tunnel syndrome, can deposit in the eyes, in the kidneys, that can cause increased protein in the urine. And more rarely, it can deposit in certain areas of the brain, although this is an exception and really occurs only in very specific certain mutations. There are about 140, a little over than 140 different TTR mutations that have been currently identified, and new mutations are being discovered all the time. Of these mutations, there's really a spectrum of clinical manifestations. So historically, things have been described as mostly cardiogenic and mostly presenting with symptoms involving the heart, or on the other end of the spectrum, involving primarily neuropathy and other neurologic manifestations. What we're realizing more and more, though, is that this is really truly an overlap of disease, and patients very commonly can have both. Amyloidosis is often an invisible disease, meaning there are really no major telltale signs on exam that someone clearly has ATTR amyloidosis. There can be a few signs that can be present, but it does not necessarily mean that a patient has the disease based on these signs. When patients have constellations of symptoms, so multiple symptoms consistent with amyloidosis, that can help physicians come to a diagnosis. So some of those visible signs of disease on physical exam, for example, commonly seen in TTR wild-type disease are spontaneous rupture of tendons. In this case, shown here is a spontaneous bicep rupture. You can see on the left, there's a big, bulky area of muscle that's kind of coming out of the skin. Sometimes we call this like Popeye's muscle because it looks like it's very bulky in this one area. And sometimes you may even see some bruising in the area. Often spontaneous tendon ruptures occur with a lot of pain, but sometimes can kind of occur on more an insidious way, and we sometimes even just see it on exam when we're looking at our patients. The common neurologic manifestations of ATTR amyloidosis are peripheral neuropathy. You may also hear polyneuropathy, autonomic dysfunction, and carpal tunnel syndrome, either on one side or even more commonly on both sides of the arms, which is seen often in patients that don't have any kind of risk factor for developing carpal tunnel. Anytime a patient sees us either in our neurology clinic or in the amyloidosis center, we do a very thorough neurologic exam, including examining strength, examining various types of sensation, including cold sensation, pinprick sensation, soft touch, and vibration. And a classic way that peripheral neuropathy can develop is often tingling numbness in the feet that then slowly progresses upwards, up the legs to around the knees, and when it gets to the knees, often it affects the tips of the fingers and eventually goes up the arms. So often patients report pain, tingling, numbness, sometimes a little bit worse at night just because they're kind of aware and focusing on it at night. And later stages may also be associated with weakness, starting in the toes and then followed by the feet. In much later stages, you can also get imbalance with walking and even difficulty with walking, requiring assistive devices like a cane or a walker. There are various neurologic tests to work up the etiology of a neuropathy. So when a patient comes to us with neuropathy, there are a variety of things that we do to figure out what's going on and what's causing it. So the first thing we might do is something called a nerve conduction or electromyography, otherwise known as EMG. The first part, which is the picture on the right, we take small sticker electrodes and put them over muscles and nerves. And then this little device that the person is holding with two metal prongs typically stimulates the nerve, and patients will feel a little electric tingling or shock. And then the second part, the physician will place a small needle in several muscles. This can help to determine if a patient has neuropathy, but also exclude other things that can cause tingling and numbness, such as a pinched nerve root in the back or something else. The second thing is additional laboratory evaluation for other causes of neuropathy. So common causes of neuropathy other than amyloidosis include diabetes, thyroid dysfunction, vitamin deficiencies like B12, for example. So we might get those labs just to make sure this is truly from amyloid and not something else. Finally, you can also do skin or nerve biopsy, which I'll go into in the next couple slides. So a skin biopsy helps us to determine if a patient has what's called small fiber neuropathy, which is a type of neuropathy that we often see in amyloidosis, and we should think about when we see pure small fiber neuropathy. Patients can have a normal nerve conduction EMG and still have small fiber neuropathy. So if our EMG is normal, we might do a skin biopsy to further evaluate to see if this is from amyloidosis. The skin biopsy is very routine, takes about 10 minutes at the bedside. It's a little punch biopsy, as you can see on the left. We take 3 areas of the leg, typically, because we have normal values that we can compare this to. And the areas heal by granulation, so basically you don't need any stitches or anything like that. We take each of these small samples and then we cut them into very small slices and look at them under the microscope. What we see in a normal skin biopsy is these small little nerve fibers in what's called the epidermal layer of the skin, so the outermost layer of the skin. But in a small fiber neuropathy, which can be seen with amyloidosis, we may see loss of those fibers in the epidermal layer, and that can give us a hint that this might be small fiber neuropathy. Neural nerve biopsy is a little bit more invasive, which is taking one of the large nerves of the leg, and we really only do this if the diagnosis of amyloidosis is in question, and we're not really sure if the cause of the neuropathy is from amyloidosis or not. This is really not useful in patients where diagnosis can be made by biopsy of other tissues easily, or for example, by PYP scan or another form of diagnosis, because it can be invasive and can leave the patient with permanent sensory loss in the leg. The treatment for any type of neuropathy is usually treating the underlying cause. And Dr. Lau is going to go over the spectrum of different treatments that we can give to patients to help with TTR amyloidosis. Symptomatic therapies include things that just help patients with the pain of the neuropathy. So common things that we give are anticonvulsants like gabapentin and pregabalin, serotonin norepinephrine reuptake inhibitors like duloxetine or venlafaxine. We do try to avoid tricyclic antidepressants, things like nortriptyline and amitriptyline, which are commonly given for neuropathy, because these medications can actually worsen the autonomic dysfunction that comes along with amyloidosis. Other topical agents, things you can put directly on the skin, include lidocaine patches and high-dose capsaicin, which is a hot chili pepper paste that is typically put on in the clinic. If patients have weakness in their legs, ankle-foot orthotics can often help them lift their foot up while walking. That can help with ambulation and balance and walking. And then finally, physical therapy, particularly if there's a strong imbalance component to the neuropathy, physical therapy can really help. Moving on to carpal tunnel syndrome, another common manifestation of amyloidosis. So amyloid can deposit in the wrist in an area called the carpal tunnel. When it deposits there, it compresses the median nerve, which causes tingling numbness in the area you see there in that photo. So patients will often come with numbness, tingling, pain, and then sometimes, if it's really progressed, weakness in hand grip. And it might be obvious, like dropping things with their hands, but it also might be very subtle, like difficulty with buttoning, twisting the cap off of a bottle, or something along those lines. If it's mild carpal tunnel, then we can give counseling about changing work habits, either at the office or at work. For example, if someone is doing a lot of repetitive wrist motions, trying to counsel them about trying to keep their wrist straight during the day. The only difficulty is at night, we really have no control of our wrists. So often we are sleeping with our wrist bent underneath us, for example. So wrist splint on the wrist at night can also help to maintain that wrist, keeping it straight. If a carpal tunnel is more moderate or severe and there's a little bit more weakness on exam, then we do recommend a decompression surgery, which is a surgery that takes that material out from the carpal tunnel, and we do recommend staining that pathologically for amyloidosis, just to make sure that the true reason someone is having carpal tunnel is from amyloid and not something else. The last major neurologic manifestation is autonomic dysfunction. So the hallmark sign of this is often lightheadedness and dizziness with standing, something we call orthostatic hypotension, because it's caused by a drop in blood pressure when you stand up too quickly. But patients often can have a constellation of these symptoms. They can have dry eye and dry mouth. They may have diarrhea or constipation or an alternating constipation and diarrhea. They may have erectile dysfunction or vaginal dryness, sweating abnormalities, either too much sweating or not enough sweating, or a variety of urinary problems. Again, just like neuropathy, the treatment of autonomic dysfunction in general is treating the underlying disease, but there are some symptomatic therapies that we can use to help patients with their symptoms. So if someone is really having bad orthostatic hypotension, counseling them about in the morning, sitting up in bed and waiting for a couple of minutes and standing and waiting before going in, instead of just jumping out of bed, because often patients, especially in the middle of the night, if you need to use the bathroom, might jump out of bed, and those are often times that patients pass out. Also recommending increased water intake, and obviously this will need to be discussed with the cardiologist in case there's something like congestive heart failure. But if there isn't, liberalizing water intake is another method to help. Compression stockings, so these are very tight socks that you wear on the feet that can also help with orthostatic hypotension. And then finally, if none of these help, then you can do something like various medications, including midodrine, fludrocortisone, pyridostigmine, or droxidopa. If patients have specific manifestations like dry eye, you can recommend eye drops. Dry mouth, you can recommend increased water intake and carrying a bottle of water around with you. GI dysfunction can often be very challenging because sometimes patients have only diarrhea, sometimes they have only constipation, and even more challenging, sometimes it alternates between diarrhea and constipation. Some things that can help this in general are, instead of 3 big meals during the day, eating very small, frequent meals spaced out at certain time intervals, and then really specific medications meant to help either diarrhea or constipation. At this point, I'm going to hand the mic over to Dr. Vincent Lau, who's going to talk a little bit about the treatment options for hereditary TTR, specifically for neurologic symptoms.
Great, thanks, Dr. Kaku. So this is one of my favorite topics, thinking about the available therapies for hereditary amyloidosis and how they really improve and stabilize the neuropathy and other neurological manifestations of amyloid. As you heard from our cardiology colleagues, a lot of these, really all of them have come out in the last decade or so, or a little bit over that. So this is a very exciting time, and it gives us a lot of hope and also gives our patients a lot of hope, of course. The way we're going to do it is that we're just going to go through the same list of medications that Dr. Siddiqui and Dr. Rupert had gone over, except that we're going to talk about the neurologic aspects of each of those things. So this is a callback to their summary slide. We're just going to start right up at the top. CRISPR-Cas9 genome editing. So as previously discussed, there is a very exciting time for CRISPR in general, obviously. The big trial that had come out in the NEJM last year had enrolled 6 patients. And so far, they have only looked at the TTR levels and found that they did decrease, and the decrease was sustained. They have not yet looked at their neurologic manifestation and whether these patients may have stabilized their neurologic symptoms. So that's kind of more information to come. Presumably, this might be the case if the TTR is, given that there's suppression of TTR, but we will kind of find out more about this, and we're eagerly anticipating the next trials for CRISPR. We're going to spend a little bit more time talking about the gene silencers and the RNA interference medications. So obviously the big two are patisiran and vutrisiran, and we're going to get into the neurologic aspects of both of these. So as we talked about before, patisiran is a gene silencer. The original study looking at patisiran is a phase 3 trial called Apollo. What they did was they randomized patients to either receive IV patisiran versus placebo, and they looked at the change in neuropathy score as their primary endpoint. And they enrolled 225 patients with amyloidosis with neuropathy. Dr. Kaku and I had debated how much detail to put into some of these slides in terms of the literature and the numbers and the graphs. In our experience, kind of working in the amyloidosis center, we do find that our patients are very knowledgeable about their the disease and oftentimes are very much up to date. So we decided that we are going to include some of these numbers and data since they might be of interest to some of you. So this is the results of the patisiran extension study. I'm just going to orient you. So on the figure on the left, that is looking at the neuropathy score. The neuropathy score is a composite score that consists of many different domains, including elements of a patient's exam. For example, their degree of weakness, their reflexes, their sensory exam, along with nerve conduction studies, autonomic symptoms. So it takes a bunch of different information and puts it into a single number that kind of summarizes or is meant to summarize the total burden of their neuropathy. So if you look at the graph on the left, the pink line is the corresponds with the patients who had received placebo. The light blue line is the patients who have received patisiran. And you can see that the neuropathy score, the higher it is, the worse the neuropathy is. So the group of placebo obviously did progress, unfortunately, and got worse over time, whereas the patisiran group actually not only stabilized at the 9-month mark, but some of them actually had improvements in their neuropathy score, which is quite remarkable. Similarly, on the figure on the right, looking at the quality of life questionnaire, this is a score that is given that asks a bunch of questions about different kind of daily living scales, and then they put together one single number to kind of summarize how the amyloidosis may be affecting an individual's quality of life. And similarly, the group that had patisiran actually had some decrease in their quality of life questionnaire, and the lower the number, the better in this case. So kind of quite exciting results from this 2021 Apollo study. Vutrisiran, just to review from the earlier cardiology talk, this is the version, kind of the same similar thing as the patisiran, except that it's given subcutaneously. It's given every 3 months, which is kind of remarkable and kind of from a patient convenience standpoint. The phase 3 trial looking at this is called Helios-A. They randomized patients to either receive the vutrisiran sub-Q every 3 months or patisiran IV, and they looked at this for for a total of 18 months. They also looked at the neuropathy score. They enrolled 164 patients with hereditary ATTR with neuropathy. And as Dr. Siddiqui and Dr. Ruberg had mentioned, Helios-B is the cardiac part of the trial. The results here are kind of interesting because by the time that the vutrisiran trial had come out with Helios, patisiran had already become available. So obviously, as therapeutics have become readily available to the population, it was no longer ethical to try to compare the effects of vutrisiran versus placebo. It would not be fair to the patients who got randomized to placebo. So what I had mentioned earlier was that they compared vutrisiran versus patisiran. But some of this data in these two graphs specifically is actually comparing vutrisiran to the placebo group of the Apollo trial from patisiran. So not the same trial, but the same kind of baseline population from the patisiran trial. So you might have to sit with that just to understand that. But this data came out this summer in 2022. Again, very exciting. Compared to the placebo group, the neuropathy score, some of it had decreased and at least was held stable, whereas obviously the placebo group from the Apollo trial had worsened over time. And in our amyloidosis center, we are starting to convert some of our patients from patisiran to vutrisiran at their request, again, from a convenience standpoint. And we are also starting to start patients who are treatment naive to vutrisiran as their first medication if neuropathy and neurologic manifestations is their primary burden from their amyloidosis. We oftentimes get asked about comparing patisiran and vutrisiran, and so there's this graph that looked at the TTR levels. When both medications are given, you can see that the TTR levels are reduced and sustained for both medications at a similar degree. Moving on to the other type of gene silencer, the antisense oligonucleotides. The first one is inotersen that we'll talk about. Inotersen is the antisense oligonucleotide. The original study that had looked at this medication was a phase 3 trial called Neurological. They have randomized patients to either receive inotersen or placebo as a sub-Q medication every 1 week. They again looked at neuropathy scale and the quality of life scores, and they enrolled 172 patients with hereditary TTR. So also positive data. So they just to orient us on the left graph, The dashed line corresponds to the patients who had received placebo, whereas the solid line corresponds with the patients who had inotersen. And as you can tell from this, the group that had received inotersen had a much less increase in their neuropathy score over time. Similar for their quality of life questionnaire, the group that had received the medication had barely changed their quality of life questionnaire score over time, whereas in the placebo group, obviously, the quality of life would worsen over time. So a positive study. Eplontersen, there's not yet a lot of data on this, and those trials are ongoing, so we're also eagerly awaiting those results. For TTR stabilizers, so as previously talked about, the big three are tafamidis, acoramidis, and diflunisal. So tafamidis is a TTR stabilizer. The original study back in 2012 looking at this was a 1-to-1 randomization trial and compared tafamidis versus placebo oral over 18 months. Again, looking at neuropathy scale and quality of life scores. They enrolled 125 patients with V30M ATTR amyloidosis. Again, positive results. So in this graph on the left, the triangle refer to the placebo group. The green squares refer to the tafamidis group. And as you can see, over time, the placebo group worsened much more than the tafamidis group. There is an extension study for tafamidis that demonstrated good tolerance long term. From a cardiac standpoint, as talked about before, the tafamidis improves survival, improves cardiac status. From a neurologic standpoint, as you can tell from the previous graphs, it definitely has a stabilizing effect. It may not have a reversed neuropathy for the most number of patients, and it does seem to asymmetrically benefit patients with V30M. And so in the US, it's FDA approved for ATTR with cardiac involvement, but not for pure neurologic involvement. Another stabilizer to know is diflunisal. This came out of a study in 2013 that Boston University was a part of, and had actually had a big role. And they had randomized patients to receive either diflunisal or placebo over 2 years, and looked at their neuropathy scores over time. They enrolled 130 patients with ATTR, hereditary ATTR. Again, the cost is very low. It's just an NSAID, and the adverse effects are what you would expect with an NSAID, mostly GI upset. Just to orient us to this results slide, these are all neuropathy scores and different versions of neuropathy scores we're looking at. Let's just pay attention to the upper left of the red box. So at 1 year, the group that had received placebo had increased their neuropathy score by 12.5, whereas the diflunisal group had increased their neuropathy score only by 6.2. And so there's a big difference. And this is sustained over time and also over different tests of neuropathy scores. So again, a positive trial. The last group of medications we'll talk about is the anti-TTR antibody. This is very early to discuss, as our cardiologist had also mentioned. The one that we're paying a little bit of attention to is the PRX004. The phase 1 trial that had come out did enroll 7 patients that reportedly did have some improvement in their neuropathy manifestations of amyloidosis, but again, very early trial. We're waiting for phase 2, phase 3 trials to come out with data, and the others are also phase 1 and kind of very too early to comment upon right now. So to review, really the TTR silencers and the stabilizers are the ones that we are currently using. And then some of the ones that we're keeping an eye on is the CRISPR therapy and then these anti-TTR antibodies. So we thought that we would end by going over a couple of cases that might be relevant to the audience here. So Dr. Kaku is going to take over and talk about the first case.
Great. So the first case reflects something that we often see in clinic and also reflects questions that patients often ask us about, which is switching therapies. So this is a 55-year-old woman who has V122I ATTR mutation, which is the most common mutation in the United States. And this was based on cardiomyopathy, confirmed with cardiac imaging, followed by TTR genetic testing. She'd been treated with tafamidis for 2 years with stabilization of her cardiac parameters. And on her annual visit to the amyloidosis center, she reported some mild numbness in the toes that had started 4 months prior. On examination, she had reduced sensation to pinprick and vibration in the feet. She had loss of her reflexes at her ankles, and these were all new from her prior visit. We did a nerve conduction study, and it did confirm that she had peripheral neuropathy. Studies for common causes of neuropathy were all normal, so B12, thyroid, and diabetes. And due to the development of new onset neuropathy on tafamidis, the patient was transitioned to patisiran. So there are switches in therapy that we often do in very specific scenarios. If a patient has a progression of a neurologic symptom or a new onset of a neurologic symptom while on a stabilizer, for example, like tafamidis or diflunisal, we do typically convert to a silencer. Also, if patients develop very specific adverse symptoms to therapy. So, for example, diflunisal, as Dr. Lau mentioned, is an NSAID, very commonly in the same family, for example, as ibuprofen. So these things can, at higher doses, cause kidney injury, stomach upset, and even in more rare cases, stroke, although this is a little bit debatable. And then tafamidis, if there's UTI or diarrhea, then these are potentially reasons to switch over to therapy. Another question we also commonly get asked is, should I be on both a silencer and a stabilizer? So in our center, we typically do one or the other, but we have seen patients referred to us on both. Use of both is safe, but really we need additional studies to kind of confirm this. There was a post hoc analysis from the Apollo phase 2 study that Dr. Lau described that found that patisiran alone or with a TTR stabilizer had very similar safety profiles than if you used one or the other, and that stabilization or improvement in neuropathy symptoms were observed in the Apollo study at 18 months, regardless of whether they had used a stabilizer prior. So in this particular case, the woman represented and reported resolution of her numbness and tingling in her toes, and her exam demonstrated some very mild vibration and pinprick loss, which was improved from the prior visit.
For our second and last case, we want to talk a little bit about quality of life and kind of what to expect with some of these therapies. So this is a case of a 65-year-old woman. She is coming back to her neurologist's office for follow-up after a diagnosis of B30M amyloidosis. A year ago, she started to have some numbness and tingling in her feet. In 6 months, it came up to her knees and then eventually reached her fingers. She was initially diagnosed with idiopathic neuropathy, and idiopathic just means something with an unknown cause or unknown etiology. However, after she experienced some mild orthostatic lightheadedness and alternating diarrhea and constipation, her neurologist suspected she may have dysautonomia, so they tested her for ATTR, and that was how she was diagnosed with her amyloidosis. The symptoms that are most bothersome to her are imbalance and fear of falls, inability to use her hands, and GI distress. So there is some literature on the effects of quality of life from amyloidosis, and in one bigger study, they had interviewed several patients with hereditary ATTR. It reports that patients found the greatest impact in their inability to walk or to use their hands. About half of patients have reported feeling frustrated and disappointed, often associated with symptom progression, loss of functioning, and the need to stop working. The majority of patients reported negative impact of the disease on their work, on their social relationships, and on their daily activities. Her neurologist explained she would like to start patisiran therapy. Starting this summer, we may also have considered vutrisiran therapy in this patient, depending on their preference and comfort level. So the patient asked some very appropriate questions. When may I expect improvement or at least stabilization? What symptoms are most likely to improve? Given that she has had symptoms for a year now and it has progressed to involve her fingers, is she too far to have dramatic improvement? So very valid questions that we oftentimes get asked in amyloidosis center. So there are different types of studies looking at trying to answer these questions. We pick patisiran just because there's some wealth of data on this. So thinking about that first question about when to expect stabilization or improvement. So this is an easy graph to look at just to revisit. We did say that, by the 9-month mark, which was the first checkpoint that the investigators had looked at, there was obviously already a dramatic difference between the group that had received placebo and patisiran. And in terms of when things improve, obviously every patient is different, but within months, it is possible to see improvement. And if you look at the quality of life questionnaire figure on the right, by 9 months, a significant number of patients actually found that their quality of life did improve at 9 months at that first checkpoint. And we don't have data before then, but I would suspect that at some point, even before then, they may notice a difference. In terms of what might improve, what domains, so there was a quality of life study based on the Apollo population, and they found that several domains of symptoms did improve. So looking at the x-axis on these graphs on the right side, you can see that the total quality of life was better with the patisiran group compared to placebo. And so this includes things like physical functioning, activities of daily living, their symptoms in general, their small fiber symptoms, and their autonomic symptoms. So basically every domain saw some difference between the placebo group and patisiran group. Some of you participate in our clinical trials, and you have answered many questions about the effects and how you're feeling. And so this has, your participation have fed into a lot of this really important data. So some of these results are also showing that virtually every symptom type did improve. So for example, if you look at the some of the titles of some of these boxes, like deep pain, electric shocks, numbness, superficial pain, weakness, etc., they get better in multiple parts of the body. So looking at those different colors, at the very bottom you see hands, arms, feet, and legs. Depending on what symptom it is, over multiple domains, over different parts of the extremities, there is improvement and differences compared to placebo. As for the patient's last question about, is it too late? Do patients who have milder versus more severe neuropathy get better benefit? So that's a great question that we oftentimes get asked as well. So again, looking at this trial specifically, in general, we think about this kind of very intuitively that early treatment is better just to slow injury and to kind of prevent injury before it begins as a principle. But a lot of these trials, and not just this one, but other trials as well, did enroll patients with a big gamut of disease severity. So in this graph, the PND is called the polyneuropathy disability score. And so patients who have PND 1, 2, 3A, 3B, different levels of severity, they all had changes compared to baseline with the treatment, and also that they were all enrolled in this trial. They all fed into the data. So we do believe that even patients who have very severe neuropathy have the potential for benefit. So we're going to end on a happy note. The patient's 1-year follow-up, she had improvement in her symptoms. She noticed improved dexterity in her fingers. She felt that her hand sensation did come back. She has some improvement in the numbness and tingling in her lower legs as well. And now the discomfort is mostly limited to her toes. So we are going to end there. And thank you so much again for your attention and your participation. We are all here, and we're excited to kind of have a dialogue and to answer any questions and to hear about your experiences. Thank you again.
Thank you.
Hi, everybody. This is Rick Ruberg from Boston. Thank you so much for spending the past hour and plus with us, and we'll do our best to answer all the questions that you have to ask us over the next 40 minutes. So I will answer the questions from cardiology with Dr. Siddiqui, who's also on the line, and Drs. Lau and Kaku will answer the questions for neurology. So the first question is about tafamidis dose, 20 milligrams versus 80 milligrams. And why don't I take that question for the cardiology side, and then Michelle or Vincent can answer for neurology. So tafamidis was obviously initially approved at 20 milligrams in Europe for neuropathy, but it was never approved in the United States for cardiomyopathy at that dose. And so the ATTR ACT trial, which was published about 3 years ago, in the New England Journal of Medicine looked at the 80 milligram dose, which is equivalent to the 61 milligram dose. It's very confusing. But the drug that was tested in the trial is 80 milligrams. It's called tafamidis meglumine, and the drug that's commonly used now is the 61 milligram dose, tafamidis free salt. But in any event, 80 and 61 are considered the same. So in the trial that looked at and this is a randomized placebo-controlled trial, both 80 and 20 made people live longer and stay out of the hospital. And the side effect profile was similar between the two. And but there was some suggestions that the 80 milligram dose could be better. And then last year in one of the European cardiology journals, using the data from that trial and the extension of that trial, investigators showed that the 80 milligram dose was probably better than the 20 milligram dose in terms of keeping people out of the hospital and living longer. And so for that reason, we don't use 20 milligrams for cardiomyopathy in the United States. We recommend either 80 milligrams of meglumine or 61 milligrams of tafamidis. Michelle or Vincent, you want to answer for the neurology side?
Yeah, same here. So we, in our practice, we also use the higher dose, and that's just kind of the typical thing. I don't think that we actually have investigated in the neurology side a difference between those two doses. Again, as a reminder, tafamidis is not actually approved in the U.S. just for if there's only neurological manifestations alone. So it's the investigators have been looking at the cardiac effects of tafamidis.
Right. That's an excellent point that Vincent made. I want to make sure everybody remembers is that tafamidis was not approved for neuropathy. It was approved for cardiomyopathy in the United States, and it was approved for neuropathy in Europe at 20 milligrams. But the 80 milligram dose, I don't believe, was tested, and that's what I didn't think so, and that's what Vincent is telling us. Shall we move on to the next question?
How long does it typically take to start seeing improvement from silencers?
Maybe Vincent, Michelle, since they're more commonly used for neuropathy, you guys want to answer that one first?
Sure. So as you, okay, I'll start and then Dr. Kat can weigh in. But as you remember, the graph that we had shown, so in the original trial looking at patisiran, the first data point that the investigators had looked at was to the 9-month mark, and that's at that point there was already a big split between the group that had received placebo versus patisiran, and then some of the reversal of symptoms was became even more evident at the next checkpoint at 18 months. So again, every single patient is different, and then people respond differently, but that's generally where you think about it in the kind of months, on the order of months. Anecdotally, in clinic, we usually see patients back at least once a year, and sometimes more frequently than that. And sometimes, depending on kind of the severity, especially early on, you really can, people do report feeling different early in the first few months, sometimes of taking the medication. Oftentimes we'll notice changes on their examination, as we talked about earlier, in terms of their sensory, in their sensory exam or even their motor exam, any weakness, that some of that tends to get better. And I think the last case had illustrated a little bit about how some individuals who report things like kind of improvement in balance or just feeling a little bit kind of having more dexterity come back. So some of those things we definitely have heard of people reporting even at the first few months mark.
Anything to add, Michelle?
Yep, I was going to pretty much talk about the same thing, which is really on the order of months. I will also say, as Dr. Lau also alluded to, that it really, in terms of neuropathy, depends on the severity of neuropathy. So if someone has had neuropathy for many, many years, has weakness in the feet, maybe the tingling numbness is well up into the upper legs, and they've already started to develop symptoms in the hands, that kind of reversal from that point might be a little bit slower and not complete in terms of, 100% recovery, as opposed to someone that just developed the symptoms in the order of months, maybe a year, maybe only has some tingling numbness in the toes without any weakness. So it really kind of does depend a little bit on the severity of presentation, but overall, we have been seeing some stability / improvements over the course of months.
Dr. Siddiqui, any experience in response to silencers for cardiomyopathy patients?
I think that because these agents are not used as frequently, they're not commercially available. I don't think I have that much to add. I'll say the only thing I'll say is that looking at both the patisiran and inotersen studies, the actual transthyretin serum levels in the blood, which is also known as prealbumin, that can drop quickly, in the first couple of weeks. So at a biological level, these drugs have an effect pretty early on. But I don't really have a good sense of how quickly people respond from a heart standpoint. Dr. Ruberg, I think you probably have more experience in that.
Maybe, but I completely agree with you. I think that unlike the nerves, the heart doesn't regenerate, and so we tend to see. I often tell patients we tend to measure the success of the drug and how well we're keeping them out of the hospital and how well they're obviously, coming back to us, and how well their symptoms of heart failure are under control. And I definitely think that that we see that kind of play out over time. But unlike in the neuropathy world, we don't have we don't have an exam we can follow as much, other than the measurable changes in the markers that are in the blood, as you just mentioned. So I want to move on to the next question. Why don't I actually go ahead and read it then? The next question is, can you join clinical trials if you don't live in Boston? Why don't we talk about that? So why don't I actually ask Dr. Siddiqui that question, going backwards in order? Can people come and participate in trials if they don't live in Boston?
Yeah, absolutely. We have a lot of patients who live really all over the country and even in other parts of the world who, especially those who live in this country, can participate in trials even if they don't live in Boston. The thing is that there's two things. So one is that if they want to participate in a trial through our center, for example, through Boston Medical Center or Boston University, they would need to be seen, they would need to be evaluated here, and then they can enroll in the trial. It depends on the trial that you're in. You typically need to come to Boston for periodic visits and to receive the study drug. So that can be an imposition, and that can, that definitely has time ramifications. Oftentimes, the drug companies will pay for your trip or will compensate you to some degree to travel. The other thing is, as more and more amyloidosis centers are developing in the country, and there's really been a proliferation in the last few years, chances are that you will have access to trials locally as well. So that's the other thing, through the Amyloidosis Foundation and other resources, to figure out if there are centers closer to your home that are also offering these trials. But to answer your question directly, you don't need to live in Boston. People come to Boston to participate in trials from all over the country.
I think that pretty much answers that question, unless Michelle or Vincent, you want to add anything from the neurology standpoint?
Nope, I agree.
Yeah, we have patients who fly in to join us and then do their studies and then kind of fly out the same day or the following day. So you're certainly welcome. And I think those patients kind of sometimes when we do see them, it's also nice to kind of connect quickly, especially if they're also patients at the amyloid center. So actually that is 100% fine and welcome.
So the next question is pretty interesting. They're all interesting, but this one I think is going to engender a little bit of conversation. And it's, how do you know whether a mutation or a variant is active or it is silent? And so the question basically is, if you inherit a variant, how do we figure out as doctors, and how do you know as patients, whether or not you're actually getting symptoms from that? So why don't we start with the neurology side? And Michelle, maybe you want to talk about your approach to what we call variant carriers and how you figure out whether or not they've got evidence of neuropathy?
Sure. So as you just mentioned, many patients may have mutations for amyloidosis and may never clinically develop amyloidosis. And we follow many people in various families with no mutations, sometimes annually or every 2 years, just to monitor them symptomatically to see if they develop clinical symptoms, so we can really catch things early and start treatment as early as possible. So from a neurologic standpoint, As I mentioned, as we sort of talked about in the webinar, the main manifestations of neurologic involvement are progressive neuropathy, bilateral or carpal tunnel on both sides of the hands that presents spontaneously without a lot of risk factors, and then autonomic dysfunction, which is really a constellation of different symptoms like lightheadedness with standing, diarrhea, constipation, dry eye, dry mouth, etc. So we really are asking every person in the center that comes to us a whole battery of questions along those lines to assess if someone has those manifestations. We also will do a very thorough physical exam, looking specifically at neuropathy and carpal tunnel, checking patients' blood pressures when they're lying down, sitting, and standing to see if they're dropping, and then doing a whole battery of different blood tests and additional testing to kind of evaluate that and work things up. So oftentimes we do see patients with a full-blown constellation of symptoms, and oftentimes the cardiologist can also comment a little bit on this, but we do want typically some sort of tissue diagnosis to see if there is amyloidosis or any sort of amyloid deposits anywhere in the body that can confirm that the true etiology of those neurologic symptoms are from amyloidosis. And we can do other testing as well in the blood, looking at other biomarkers to sort of confirm that. But again, neuropathy can be a very challenging diagnosis in that there are probably around 100, if not more, different causes of neuropathy. Most common ones being diabetes, vitamin deficiencies, thyroid dysfunction. So our job in the center is to figure out if they do have neuropathy, is this from amyloidosis or not?
That was great, Michelle. Thank you. That's the challenge we face in cardiology as well, because there are many different manifestations of symptoms people get that could be from the heart, and amyloid is only one part of that. So Omar, what's your approach to a patient who comes to you, as we often see these patients in our clinic, who know that they've inherited a variant? Situation is either their parent has a variant and they got tested, or they increasingly commonly are sending their blood off for an ancestry test or a 23andMe type genetic test, and the result comes back they've got T60A or V122I. How do you approach those people to figure out whether they've got evidence of amyloid cardiomyopathy?
This is a really good question, and there are multiple ways to answer this, but I'll try to keep it brief. So one thing is, how do you know if a mutation is causing a disease or not? And one part of it is we know mutations that are associated with hereditary transthyretin, so V122I, T60A. So that's one set of cases where somebody comes in, they have those known mutations. And in that case, we try to figure out whether the fact that you have inherited a mutation from your family, from your ancestors, whether that means that you're going to definitively get the disease at some point, and that's known as penetrance. Whether a mutation results in the disease, and we actually don't know if every mutation is 100% penetrant. We don't know if every single patient will get the disease, and so in the cardiology world, we look at a few, and that's why when you come, for example, to an amyloidosis center like the Boston University Amyloidosis Center, you will get like a two-day visit where we will run multiple tests, and those tests include blood biomarkers. So we look at things like troponin and BNP, and these are markers that leak from the heart as a sign of heart damage. And in the absence of other reasons, they may signal the onset of amyloidosis in the heart, potentially, but they need to be interpreted in the context of who you are as a person. And then the other thing we look at is the echocardiogram. We look to see wall thickness of the left ventricle, the pump of the heart, to see, because as you know, amyloid protein deposits in the heart causing the walls to become thicker and the heart to become stiffer. So we look at that. Nowadays we have nuclear medicine technologies that allow us, in a very sensitive manner, in the case of transthyretin amyloidosis, to see if there is increased uptake of these radio tracers that bind to transthyretin in the heart. So needless to say, we have fairly good diagnostic techniques that allow us to figure out if there is potential potentially transthyretin depositing in the heart. So that's one thing. Sometimes, though, it's unclear to us, these tests can be equivocal, and we're not sure if they're actually causing problems. And so we may follow people sort of expectantly and see how they do. We may, if we're totally not sure, what's going on, we may actually go ahead with like a heart biopsy to try to make a more definitive diagnosis. So that's one set of cases, those mutations that are known to be pathogenic. There are other mutations in the transthyretin gene that are not known to be pathogenic, and we do occasionally find those as well, where we're just not sure if this is going to cause a disease, or we know that it's in a part of the gene that doesn't cause problems. And that is sort of a separate set of cases. But yes, it can take some thought, and it can take a lot of sort of diagnostics to try to figure out if a particular mutation is causing disease.
Thanks so much, Omar. I think that so as you all can hear, it's pretty complicated, and it really helps to be, I think, seen as an experienced amyloid center where we kind of are on top of the latest ways in which we figure out whether a gene that you may have inherited or a patient may have inherited is causing a problem. But I think the key points that were made by both Michelle and Omar are that just because you've inherited an allele that we know causes amyloidosis doesn't mean you either have amyloidosis or you're going to get amyloidosis at any time soon. It really depends on how old you are. It depends on the variant. It depends on how the variant may have expressed itself in your family and other factors that we don't fully understand. And so I think that's a really kind of important point that will maybe kind of assuage some concerns that people may have, especially about their children and passing on, a gene that could potentially cause their children the same problems that they're suffering with. So I wanted to move actually now to another line of questioning that's reflected in the chat from the participants, and that's about cost. And we spent a fair amount of time talking about that in this webinar. And so I thought maybe why don't we start with Vincent and talk about your experience with getting patients onto the various different silencing treatments that we have now for ATTR amyloidosis. What's the cost to them? And there's also another kind of question about the pre-medication. So I thought we could talk about just the patient experience of taking these drugs. What's the cost and what's the experience like?
Sounds good. Maybe we can start with the pre-medication because that one is actually fairly easy. So patisiran, in their original trials, they did have patients also take a pre-medication at about 60 minutes before receiving the medication. And so these are pretty kind of run-of-the-mill medications to prevent infusion reactions, like a low-dose steroid and Benadryl. The nice thing about vutrisiran, the injectable form, is actually there is no pre-medication, which again makes things a little bit simpler. So every 3 months injection without needing a pre-medication. So the cost question is much more difficult to answer and kind of much more nuanced actually. So we've kind of been very lucky in Boston with the Amyloid Center that we look for prior authorization for these medications really early. I will say that, obviously we're very empathetic to the fact that, these medications, even though the costs are decreasing over time, are still kind of extremely expensive, and definitely out of pocket is not really the viable option at all for almost all patients. And so it's working with patients' insurance and working with companies directly to get the help that we need. Especially with the newer things that are coming out, we're actually finding that there's really, really good support from the pharmaceutical companies themselves in terms of trying to look for different ways to pay for some of these medications. Kind of to contrast with some of the newer approved medications, obviously diflunisal is the one that is the most easy to get, and then the injectables and infusion, the tafamidis, those are the ones that are cost prohibitive for a lot of cases without coverage.
Thank you very much, Vincent. Michelle, any additional comments you want to make about that? You don't have
to. No, but just I would work with your provider to explore all options if cost is an issue. Many of the drug companies that sell these drugs do have programs and cost-assistive programs to help patients that really need the drug get enrolled and get the drug that they need if it's clinically necessary. So I would just make sure that your physician is aware of all of these and that you also do your due diligence and kind of do some searching online directly to the companies to see if there's any help that you can get if for whatever reason it's not covered under insurance, or even after insurance you still have a high copay, for example.
Oh, and I forget to, I would add about trials as one way to kind of bypass this problem in those kind of rare cases where you really have a lot of difficulty depending on your geographic location or kind of your insurance or your state. So clinical trials is another way to get access.
Right, exactly. I was going to make that point, and I appreciate you doing so. Now, from the cardiology side, I think I'll give Dr. Stiggy a break for a second, and I'll answer the cost question. As we discussed in our presentation, there's only one drug currently approved in the United States for cardiomyopathy, and we expect that will probably change. We hope that'll change when the new trials, or the trials that are presently enrolled, will read out their results, and they're already starting to be honest. But tafamidis is the only approved drug. And tafamidis is, as Omar mentioned, the most expensive cardiovascular therapeutic marketed. And I will say that most patients that we treat are able to qualify for some degree of assistance. Now, how does that work? Well, basically, there are a couple of different ways. So the out-of-pocket cost obviously is very, very high. And most patients don't bear the out-of-pocket cost because they couldn't. And so people who have insurance usually have copays that are assigned by their insurance that also can be rather high. Now, if your income is below a certain threshold, and that varies depending upon the state you live in and things like that, but you can often qualify for free drug entirely through the Vindamax program that Pfizer runs. In addition, a number of hospitals have the capacity to access foundation grants that can also offset the cost of these medications. So it really varies depending upon your income level and where you are about your capacity to access drug for a cost that's reasonable to you. And that's one of the reasons, one of the, I think, major challenges to I think the fairness of distribution of these drugs that we're working on trying to overcome. So there was also a question about 20 milligram versus the 80 milligram dose. And in the United States, the 80 milligram dose and the 61 milligram dose are approved for cardiomyopathy. So we can't get the 20 milligram dose for you, or we would not prescribe that for you, and it wouldn't be a cost savings measure. So Omar, do you want to add anything to that? I don't want to steal your voice entirely, but I want to give you a break. Okay, that sounds like he doesn't have anything else to add, so we'll go on with that. So the next question I thought would be kind of interesting to address is a question about kind of ocular or brain involvement, and this is obviously an uncommon amyloidosis variant, so we probably should spend appropriate time on it, but also move on. But I thought maybe Michelle or Vincent, you can speak to your experience with those particular variants. There was a question about diflunisal versus tafamidis. Obviously, you can talk about other agents that are possibly effective for leptomeningeal or ocular. Go ahead, Michelle.
So there are a few mutations of the roughly 140 different TTR mutations that specifically cause this thing called oculoleptomeningeal amyloidosis. So as we discussed a little bit in the webinar, transthyretin is naturally produced in our body in the liver, but also small amounts in the retinal epithelium of the eye and also the choroid plexus, which is where the cerebrospinal fluid is created. So there are some variants that predominantly produce deposition in the eye as well as in the brain. And these patients can have these seizure-like episodes. We call them like transient focal neurologic deficits. They may also have seizures, cognitive problems, weakness, numbness on certain sides of their body, and then also vision changes. So unfortunately, at this time, none of the medications really cross the blood-brain barrier, so either stabilizers or silencers. There are I think, was one study that showed that maybe tafamidis crosses in a very small amount into the brain. But there is a barrier between the blood and the brain called the blood-brain barrier that serves us because it prevents things in our blood from getting into our brain, but unfortunately that also includes medications. There was a couple of small studies looking at something called tolcapone, which is a COMT inhibitor, a medication that is commonly used second or third line for Parkinson's disease, that has been found in mouse models to stabilize transthyretin and does cross the blood-brain barrier. So we did a very small study here of about 10 patients where we gave tolcapone before and after for about a month, and did cerebrospinal fluid studies, so lumbar puncture before and after giving it, and we did find that there was some stabilization of TTR in the cerebrospinal fluid. We did not correlate this to imaging findings or to cognitive studies, and it was really kind of too short of a period to extrapolate anything from this. We're hopeful that maybe there could be a larger study to look at this agent and see if it would be helpful clinically, but at this time, unfortunately, there are no specific medications for these mutations. That said, if a patient has oculoleptomeningeal amyloid and they have neuropathy and they have cardiac disease, we do try to put them perhaps on a stabilizer or a silencer in hopes of maybe there is some small improvement, but with the understanding that, again, it does not cross the blood-brain barrier. Does that answer our question?
Yeah.
Sorry, that was a little...
No, it was great. Vincent, anything else you want to add to that?
No, that's very comprehensive.
Okay, I'm going to go with one last question, and then unfortunately there are so many questions which we'd love to get to, and I think, I wish we could answer them all, but we have unfortunately limited time. And I'm going to ask Dr. Siddiqui and Dr. Lau to answer this question. It has to do with how do you know let me back up. Now that we have different treatment options, certainly for neuropathy, and we hopefully will soon have for cardiomyopathy, how do we know whether someone is responding? And how do we know then whether we should switch someone to another agent? And that's again right now in tafamidis. I'm sorry, in cardiomyopathy, as I said, there's only one treatment option, but hopefully soon we'll have more very soon. And in neuropathy, we have a number of different silencing medications we can try. So Omar, how do you determine the effectiveness of a treatment? What do you tell people to expect in terms of the effectiveness when you put someone on tafamidis? And when do you start thinking about whether or not they should be on something else? I don't know if is Dr. Siddiqui answering, or is he still there?
I wonder if he had some technical issues earlier. Maybe I can start first and we can see if he makes it back. Okay. That's a really wonderful question and really an important one. So at our center, we see our patients at least once every year. So the 1 year mark is kind of a big data point. As we had reviewed earlier, some of those first data points from at least from the trials were kind of at the 9 months or 1 year. Like that's kind of the time point when you hope that you would see an effect by that time. So one of our big jobs in the Amyloid Center is to really do a very detailed history to get a sense from the patient standpoint, kind of how they're doing in terms of their symptoms, such as numbness and tingling. We ask questions about their function, kind of how far can they walk, how's their level of coordination, how's their balance. And then the big one, and the people who have come to our center knows that we do a very detailed neurological exam. So this is us testing the strength of every single muscle. We do a detailed pinpoint with a safety pin to check every single part of the toes to see your sensations there. We check vibration. We check your reflexes. We have every patient walk for us and see how functionally how they're looking. And then obviously some of these things are a little bit subjective. We also calculate a score. It's called the NIS, or the neuropathy impairment score, and that's the score that's actually used in a lot of the studies looking at amyloidosis, so that we have some kind of objective number. And then based on that number and based on kind of looking at the patient as a whole, we try to decide whether or not the patient is either improving, either looking exactly the same as a year ago, or whether they might be experiencing some kind of decline. And even in any of these situations, we also do want to look for any competing causes. So let's say that the neuropathy is worse, but if an individual has also developed diabetes in the past year, then we wonder whether it's coming from the amyloid or the diabetes. So sometimes we'll do additional testing, such as recommending another nerve test or adding on a skin biopsy, because it's actually really, really important to figure out whether or not an individual is responding to treatment. So once we have all this data and we've kind of talked it over among the neurologists and cardiologists and other specialists as well, and to make that determination. And that's when we really kind of come back to the patient and let them know whether we think that they might be progressing through treatment. And if that is the case, then as Dr. Ruberg has said, there are multiple things that are available in the neurology space now that you can switch people onto. And enroll individuals into trials if that's the case, if they're not improving with treatment. So there's definitely not kind of one straight answer, and this is obviously what we need to do is kind of a very comprehensive evaluation, and then making a decision together with the patient.
Thanks so much, Dr. Lau. So Dr. Siddiqui, how do you, I think you're back now. I hope you're back.
Yes, I'm back.
Wonderful. So how do you determine the effectiveness of therapy in the cardiomyopathy patient, and whether or not you want to reach for something else, like a clinical trial for now?
Yeah, that's a great question. Can you hear me, Dr.
Yes.
Ruberg and others? Yeah. Okay. Perfect. So that like Dr. Lau said, that is the subject of our multidisciplinary discussion every week, where we sit and discuss every patient and we try to figure out whether they're responding or progressing. So from a cardiology standpoint, there are a few things that we look at. We talked about how we evaluate people's blood work, and we look at biomarkers that leak from the heart as a sign of damage to the heart. And those are the same biomarkers, troponin and BNP or NT-proBNP, that we follow longitudinally. So when we see patients every year or so, we will check those biomarkers in the blood, and we'll try to see if there has been a change. And we also look at, the most important thing, honestly, is how people are doing. So we ask you how you're doing. We get some sense of physical functioning. How far can you walk on level ground? How far, if you can climb stairs, how do you feel? Sometimes we might even do objective testing, where we have you walk on a treadmill. We do like a metabolic stress test or a cardiopulmonary exercise test to give an objective sense of how much can you do and how that's changing over time. We look at blood biomarkers, like I mentioned. We look at heart ultrasound. We look at an echocardiogram, and we try to see if there has been a change, for example, in wall thickness. I will say that wall thickness is a relatively insensitive way of measuring progression, because it doesn't change that much very quickly. And we're also not very good at measuring small changes in wall thickness, but that is something that we do look at. And so it's sort of a comprehensive evaluation consisting of how you're doing, how much you can do both subjectively and objectively, what your blood biomarkers are looking like, what the echo looks like. And then Dr. Ruberg asked another question about, what do we tell patients in terms of things like tafamidis? So as you know, tafamidis is a stabilizer. It stabilizes the transthyretin molecule, preventing it from breaking down and depositing in the heart. To be honest, a lot of times what we tell patients is that tafamidis hopefully will slow the progression of disease, but it will not make them feel better. And the reason for that is amyloidosis works at basically works at two levels. You have the factory that creates the abnormal protein, in this case, transthyretin. Transthyretin circulates, breaks down, and deposits in the heart. When you come to us with symptoms of amyloidosis, those symptoms are being caused by the amyloid fibrils that have already deposited. And so our treatments that are so far approved, are not going to change that. The amyloid that has already deposited in the heart continues to be deposited in the heart and continues to cause problems. And those problems may slowly progress with time as the heart remodels and scar tissue develops and all of that. Our hope with these drugs, with tafamidis, is to slow down the rate of progression. And so it's actually very important to sort of manage expectations, because your symptoms are being caused by the amyloid already deposited. Tafamidis is probably not going to change. It's not going to change that. It hopefully will prevent progression or will slow down the rate at which you progress. With the gene silencers, we feel that now you are attacking the factory that produces this protein. It will drop the transthyretin levels to zero or very close to it. And so hopefully it'll also prevent progression. But again, and in the neuropathy trials, I think there is some signs of improvement. In the cardiomyopathy trials, we're still trying to figure that out in the heart trials. But that's typically the guidance that we give patients, is that we're hopefully preventing progression, or we're slowing down progression, but that their symptoms may continue to persist. Dr. Ruberg, would you add something to that?
No, I completely agree. I think that was really well kind of articulated by both of you, and yeah, I think it is kind of a bit of a black box. So we really, we don't. These are all kind of, this is our experience, and there are certainly expert sort of consensus opinions about how we should figure this out, but we really do need better evidence, and I think that will be forthcoming in some future studies. So I learned it's 4 minutes before the hour, and I think we have time for one more quick question before we unfortunately have to sign off. And again, there's so many good questions. But I think one of the questions that I wanted to ask that came from the list, and I'm going to start this one with Dr. Kaku, and that is, what can people do who may have inherited a variant but don't yet have disease, or are not really, are kind of just at the beginning. They don't quite qualify for a silencer, and I think you probably understand that I'm leading you towards a particular direction. So I hope that's not too obvious. But people, I think, want to feel like they're just not kind of waiting around for something bad to happen to them. They want to feel like they're taking some action. And so what can they do, and what can we do for them?
That's a great question. So as we discussed a little earlier, sometimes patients come from families that have known mutations with active disease, but the patients themselves either are asymptomatic or might have very early symptoms. So I would say the first thing to do is actually try to be seen by amyloid specialists. So as most of you know, this is a very rare disease, although probably not so rare, probably just underdiagnosed in the community. So going to a center like BU or a center near you where they see amyloid patients very frequently, I would say is probably the best first step, because amyloid can deposit in so many different organs and cause so many different presenting symptoms. They may end up in a gastroenterologist's office, a cardiologist's office, neurology, rheumatology, renal, it really just depends on where the amyloid deposits. So oftentimes patients frustratingly need to go to many different providers before coming to a diagnosis of amyloidosis. But if you know you have a mutation and you're just not sure if it's manifesting itself, again, I would go to an amyloid center where a variety of physicians can evaluate you, can do all the things that Dr. Lau mentioned in terms of examination, neurological examination, and all the things that Dr. Siddiqui mentioned regarding cardiac evaluation and every other organ system, including various blood work. As was discussed earlier, we all sort of meet as a multidisciplinary center every Friday, and we discuss every single patient that we see in detail to really determine whether or not a patient is presenting clinically with amyloidosis. And if they are, then the key is to really get them on something sooner rather than later, because as we also know, the earlier you can get a patient on a medication, the easier it will be to stabilize and hopefully ultimately reverse some of the symptoms that they're experiencing. Is that sort of where you were going, Dr. Ruberg, or is there a specific pathway you wanted me to discuss?
No, I think that's the point. I also wanted to talk a little bit about whether or not we could utilize diflunisal in certain circumstances. Maybe you want to just, we don't have much time, and I apologize for that maybe leading question. But we as a center, we certainly are using that more than maybe other doctors in the community are. So do you want to take just a minute to talk about when you might consider that?
Sure. Yes, sure. So if a patient, for example, there are some patients that have very, very early what we call small fiber neuropathy, as we discussed in the webinar, that may have generally almost negative testing with an EMG, which is looking at the nerves of the legs, for example, or very mild carpal tunnel, no tissue involvement that we could find, but we know that they have a genetic mutation that maybe at this same age their parents had also presented. We may put this group of, or this population of patients on diflunisal. which again is one of the TTR stabilizers. That is an NSAID, so over-the-counter nonsteroidal anti-inflammatory. This medication is relatively cheap compared to the other medications, with relatively little side effects or contraindications, except for things like kidney disease or gastritis. And we will often monitor these patients very closely and looking out for any kind of progression of disease or symptoms. But that sort of conversation I could probably expand upon much longer, but I know we're out of time, so I apologize.
Oh, no, thank you for introducing it. That's what I was kind of implying as well. So I think we've reached the top of the hour. So why don't I want to thank everybody for joining us today, and my colleagues, Doctors Kaku, Lau, and Siddiqui. And so any final thoughts, just a few seconds before we kind of are done from Doctors Lau or Siddiqui?
Oh, just thank you for having us. This is great.
Yeah, same. Thank you. This was really well done, and many thanks to the Amyloidosis Foundation for doing this as well and for serving as a resource for patients and physicians. So, and then thank you to my co-presenters.
Thanks so much. Okay, we're ready for, I think, our wrap-up.
Okay, and on behalf of the Amyloidosis Foundation, we would like to thank you for your participation in today's event. This concludes today's program. Thank you and have a great day.